I want to start here with a simple quote, if you'll allow me. Developing better health and care services requires constructive cooperation with the health industry, both at a national and international level. The Norwegian government's 2018 white paper goes on to state that the government wants to take steps to improve the interaction between the health and care services and different private and nonprofit parties in the health innovation ecosystem. Friends, our hands have been forced in terms of public-private cooperation in healthcare by COVID-19. Since March, things have taken a dramatic step in what we would consider a positive direction in terms of collaboration. In fact, it's not been since March that we've been able to meet together in person, so I would like to warmly welcome all of you and thank you for being with us today. It's good to see so many people live for a change. We will see if this is able to continue. We have a very special topic and timely topic, public-private stronger together, building a resilient and sustainable healthcare system in Norway. Building upon the mentioned momentum of COVID-19 public-private sector collaboration and coming together for a common goal, and I want you to keep these questions in mind as we move ahead today. What does a resilient and sustainable healthcare system look like for Norway? What is needed to secure this vision together? What have we learned from COVID in terms of mindset and behaviors we need to take forward to support a continued constructive public-private sector approach? And finally, how will we know if we are being successful in this endeavor? We have a fantastic panel lined up. We have Dr. Atun from Boston joining virtually. I'll put him on screen in a moment. And we have 5 distinguished panelists. You see their names here. I will introduce them after Dr. Atun's initial remarks here. I'm going to try to now put you up on screen, sir. Bear with me one moment. Almost. While we're getting him on screen, sir, if you don't mind, I'll go ahead and give your brief background. Dr. Rifat Atun is the professor of global health systems at Harvard University's T.H. Chan School for Public Health. His research is currently within 2 primary areas. The first examines health systems performance and how design and implementation of health systems reforms impact on outcomes. The second research area explores the adoption and diffusion of innovations in health systems and innovative financing in global health. Professor Atun has worked with more than 30 governments globally, as well as the World Bank, the World Health Organization, and the UK Department for International Development. He has also worked with the Norwegian Research Council's Global Health and Vaccination Research Board. It is an honor to have you with us today, sir, and the virtual floor is yours.
Thank you, Jason. Yes.
There. I can see some of the audience participants here with us.
Yes. Yes.
We saw your slide for a second. There it is.
Yes. Can you? Okay.
Yep,
good.
We see it.
We are so dependent on technology. Well, thank you for this opportunity. It's an incredible privilege and honor to contribute to this important meeting. Very timely and very pertinent given the COVID-19 experience in the world. So my presentation is going to focus on sort of 3 major areas. First, I'll briefly talk about the context, then briefly visit the response to COVID-19 and health systems responses generally, and then spend some time on the opportunity, especially what the new context means for public-private partnerships. Well, I think we're all fatigued with not just COVID-19, but with the data and the numbers. But today, we exceeded 20 million cases and have reached almost 700,000 deaths. And of course, these are huge underrepresentations. The numbers are far, far greater. But what COVID-19 has really shown us is that the debates between wealth and health and wealth is no longer a debate. We've seen the impact of COVID-19 on the wealth of countries, on the wealth of individuals, health of populations, but very importantly also on social cohesion and security. So we have a completely new context where we cannot ignore health as an integral part of well-being of a country and the world as a whole. The economic impact of COVID-19 is going to be huge. Only yesterday, the UK announced the worst numbers ever on record and worst performer in the European context. And the IMF projections in April were projecting a decline of 6.1% in advanced economies. But by June, that was revised down to 8 points, and even a big decline in emerging markets. Very different to 2008 economic crisis, where the declines were about 1% globally. But the consequences go well beyond health and the economy. And we're seeing unemployment, issues around food security, even in advanced countries. Social compact is being undermined. The social attitudes to science are being crystallized into those for and those against. And we're seeing a social polarization. And this is a picture of sort of networks. So we're becoming for or against, as opposed to this sort of heterogeneous and integrated social groupings that we've had in countries. And what COVID-19 has shown us, and I think this is probably the most important message from this presentation, this is the interdependence and interconnectedness. So I think this argument about public versus private, I think that's passé. It is really not really relevant. We're all in this together. So the question is not whether public and private sector should work together. The question is, how can we make this work in a way that's going to benefit everyone and that's going to create opportunities for developing sustainable health systems that can contribute to sustainable development, social cohesion, and security in countries, but also globally. But let's look at the response to identify where we have gone wrong and where we can improve. The health system responses to COVID-19 have varied in countries, but in many countries it was ineffective, inefficient, inadequate, and inflexible. And in the European context, we've seen terrible needless deaths in countries that have had well-functioning, so-called well-functioning health systems. Now the epicenter has shifted to Americas, and we're seeing huge consequences in Latin America. And the epidemic is now moving to Africa, where health systems are particularly weak. But some countries have performed well, especially those who've had in place good governance, with strong leadership, good command chain, consistent communication, and reliance on science, with policy agility to respond. Countries that have been able to use fiscal space and budget flexibility, those that have invested in partnerships, in maintaining supply chains and scaling up production capacity, countries that have used technology for testing, tracking and tracing, and data and analytics, countries such as South Korea and Taiwan, for example. And in relation to healthcare services, we've seen that response was agile and augmented in countries that were able to use technology, but also invested in public-private partnerships and use innovations to respond. And outcomes have varied. So there are countries still going through the first wave. There are countries that experienced a V-shaped response, such as Austria, for example, in Europe, and Slovenia or New Zealand, and many of the South Asian countries. Many countries are going through this wide U-shaped response, and in many others we are seeing a W-shaped response, for example, in the US, with the second wave coming through. So there's some important lessons to be learned. But one important message, certainly for me as someone who's been working with health systems for more than 30 years, and I had the opportunity to work with more than 100 systems when I was at the Global Fund as head of strategy, is that health systems have not been able to respond to changes and transitions. And COVID has really unmasked the decline and the sheer magnitude of underperformance that already existed. So let me give you some examples. So this is a study we published recently in the Lancet that looked at management of hypertension in 44 low and middle income countries, representing about 60% of the world population. And as you can see, it's a cascade of care looking at for every 100 individuals that is hypertension, how many people have their blood pressure measured, those who are diagnosed, those who are treated, and those who are controlled. In Latin America and the Caribbean, the control levels are about 25%. In Southeast Asia, the numbers are less than 15%. Middle East and Central Asia, around 10 to 15%. In Sub-Saharan Africa, well below 10%. So health systems are not coping even with the commonest chronic condition. But you might say these are low and middle income countries. What's the relevance to advanced countries such as Norway? But actually underperformances, not just in low income countries, is pervasive. So if you look at the efficiency of health systems in Europe, this is in the European Union, compared to the efficiency frontier of what is being achieved by some countries, we can see underperformance for many countries at the same per capita health expenditure and health systems. So there's a huge inefficiency and welfare loss in health systems. There's also ineffectiveness. So I pulled just a couple of figures from OECD database and included Norway as well. These are the latest data. So for example, management of asthma. Hospital admissions vary almost 4 to 5-fold. Norway is doing relatively well. Very few admissions should be for asthma. This is a condition that should be managed in the community, at home, or at primary care setting. But in many countries, there are many unnecessary admissions, what we call avoidable admissions. The same picture with diabetes. Again, huge variation, huge ineffectiveness in the way we manage these common chronic conditions. So the systems are inefficient, they're ineffective generally, they're inequitable, and they've been not inflexible in the response. And the question is why? Well, I think the reason is because we have this innovation misalignment. This is an op-ed I did for the Financial Times a couple of years ago, where I noted that scientific developments have spurred unprecedented delivery of innovations in new medicines, new medical devices, new diagnostics, but innovation in care delivery has faltered. Not much has happened. And when saying that, I was being quite generous. So if you look at delivery of innovations, we have lab on a chip, we have big data and incredible analytics with machine learning, artificial intelligence. We're transitioning from population level health to highly precise population health and precision medicine. But in innovation and delivery, we have not progressed. So this is a picture of Hôtel Dieu de Paris, the oldest hospital in the world that is still functioning as a hospital. It was established in 651, 7th century, still functioning as a hospital. So the delivery models have not changed that much. And if we look at the behavioral interventions we've used to manage SARS coronavirus 2, they date back to medieval times, to 14th century. So quarantining of ships, voluntary behaviors such as hand washing, social distancing, face masks. These go back to 14th century. And it was very interesting that with face masks, there's been a huge debate whether we should or we should not be using face masks. But we didn't have the research evidence until very recently. But still, people are debating whether what type of mask, how often, where. So on the delivery side, we've not done very well. So why is this important? Because if you look at the expenditure on medicines, diagnostics, and consumables in the OECD is between 8 to 16% of total health expenditure. I've also included Norway here, where expenditure is around 8%. This is where the innovation is happening, and this is where the big debate around cost reductions, cost containment is happening. The big part, the 90 to 92%, the delivery part, where the innovation is not happening, this debate is not taking place. As a result, we have huge inefficiencies. The World Health Organization estimates that around 20 to 40% of health expenditure is wasted. So there's huge potential for improving the way we use resources that are available to us. But we need to focus on the system as a whole, not just a subcomponent, and create an ecosystem for innovation to happen. So the second reason why we have this innovation challenge is a policy misalignment. And this happens in most countries. I enjoy reading your white paper where you're beginning to address some of these issues in Norway. So on the one hand, we have industrial policies that energetically push innovation, encourage innovation, developing new industries, new technologies. But health policies on the whole constrain innovation, or they're designed to constrain innovations, or their uptake in systems. And economic policies on the whole tend to be detached from both. And also they discount from health systems contribution. So what's important going forward is to create an ecosystem where health policy, industrial policy, and economic policies are aligned to create a setting where innovation emerges, but also innovation is taken up and diffuses at scale to have population level impact. So to get to sustainable systems and to ensure security, we need to address issues of ineffectiveness, inefficiency, inequity, and inadequate responsiveness to external shocks such as COVID-19. But there's an opportunity given the magnitude of the challenges that we face and the underperformance that is pervasive in countries. So the opportunity is to develop sustainable health systems by increasing their agility, by embedding innovation into day-to-day functioning of systems, but also developing resilience. Now, and there are a number of transitions that can make this possible. The platforms are emerging. The first transition is in science, where our understanding of biology, our use of big data and analytics is enabling us to move from population-based interventions to management of subpopulations, for example, use of monoclonal antibodies or precision population health, to highly individualized therapies, such as immunotherapy or precision health, precision medicine. So this transition offers incredible opportunity in not just generation of new diagnostics and medicines, but also their application in populations at scale. The second transition, which is critically important, is the incentive systems and the payment systems that need to change. And this is beginning to happen again. So in the past, the focus on resource allocation has been very much on structures. So money followed structures such as provider institutions or inputs such as medicines or technology. But many countries realized that this approach was not appropriate, did not lead to improved outcomes or improved efficiency. So they transitioned to a functional focus where money followed activity. But again, this did not lead to the desired level of efficiency, effectiveness, and outcomes, as I've illustrated to you. But now we're transitioning to a value focus, where payment follows value. And what we value is individual outcomes, both in terms of clinical outcomes and reported outcomes and population level outcomes in terms of health, financial risk protection, and user satisfaction. And it's very important to note that G20, the current G20 presidency, has put value-based healthcare as a priority as one of the priorities that should be shared in the communique as and when this is agreed in the next 100 days. But for this to happen, to harness these opportunities, we need to invest in people that can innovate, that are open to innovation. We need to invest in partnerships. We need to use existing platforms in all sectors, and we need to develop appropriate policies to enable the creation of such an ecosystem. Now, the current landscape for public-private partnerships is quite fragmented. So there's a lot of outsourcing going on, and these tend to focus on hotel and ancillary services, clinical support services, purchasing of medicines or diagnostics, or in some settings in European context, also even outsourcing core clinical services. But given the transitions that I've mentioned, there's an opportunity now to actually rethink the public-private partnerships to create enabling platforms for developing innovative health systems, innovative platforms in terms of data, in terms of communication, in terms of analytics, in terms of resource management, but very importantly, is an incredible opportunity for developing integrated health solutions that brings together new advances in data analytics, risk stratification, personalized care pathways with use of personalized diagnostics and medicines, and new financing methodologies to ensure that we're able to harness not just effective solutions, but also the way they're delivered to improve efficiency, but also ensuring a level playing field so that what is provided is equitable to benefit all the citizens in a country. To do that, to transform health systems through new public-private partnerships, we need to take a step back and think, what do we need to do to create this enabling context? And here I offer you 4 C's. First of all, we need to consult widely, work multi-sectorally, work with citizens, the users of the system, to jointly identify what the system challenges are for them. Secondly, challenge the current practices and benchmark performance. We're not very good at that, as I've demonstrated to you. For many indicators, we don't have good quality data. As a result, we are losing huge amounts of resources every year. In the US, for example, $1 trillion are wasted each year out of 3 trillion that are spent on health systems. Third, co-produce, co-design, and co-implement solutions, working across sectors and within sectors. And fourth, work together to create an ecosystem for innovation, both the generation of innovations, but very importantly, their introduction into systems and their rapid uptake to lead to outcomes. So this is my final slide. To make this happen, and you've articulated some of this in the white paper, the 2018 white paper in Norway, we need to bring together universities that are the hubs for science and technology with industry that can harness this science and technology and develop it further. But very importantly, we also bring health systems into the picture to ensure innovations are applied and iteratively refined and developed so that they can reach scale and they can have population level impact. So I think COVID-19 has led to very adverse outcomes for health, economies, and social welfare of countries, as well as social cohesion and security, but I think provides an incredible opportunity for us to work together to create new forms of public-private partnerships to benefit all. As they say, never let a crisis go to waste. Thank you very much for your attention.